Hello. The field of glaucoma has seen tremendous advances in the last decade or so, and we have here with us today someone who has contributed significantly to these advances. Welcome, Dr. Sanjay Asrani.
Thank you.
We're recording these questions in the form of an interview for distribution amongst all the POS members. So, with the benefit of your years of experience, what would you say a basic glaucoma evaluation includes? That is, besides the gonioscopy, 90D and disc evaluation and the applanation.
Part of the glaucoma evaluation should include mainly the history. History is very important to be taken from the patient as to what their previous medications for their eyes have been, their oral medications, their family history of glaucoma, history of injury to the eye, history of migraine, history of low or high blood pressure, and things like that. In terms of even blood pressure control, how compliant they are with their blood pressure medicines, that can give a clue to compliance for glaucoma medications. In the examination, it will definitely include the refractive error, that is to know is the person a high myope or a high hyperope, because that can clue you in as to what kind of glaucoma are you looking at. Is it a low tension glaucoma in the case of a high myope, or is it a angle closure glaucoma in the case of a hyperope? Besides that, as everybody knows, one has to do a good gonioscopy, but one must preface that with a good von Herrick test as well, because that can clue us in what the angle is under normal lighting conditions. The state of the lens is important, because if the patient is having an incipient cataract that might be contributing to the glaucoma, one can remove the cataract and help pressure control. Optic nerve evaluation is important in terms especially of nerve fiber layer diagnosis of nerve fiber layer defects, and measurements with other ancillary testing, if available, can be helpful, but a 78 diopter lens is pretty much all that one really requires. Intraocular pressure is important, but it is more important to collect that over time rather than one snapshot.
So, you've done a lot of work on anterior segment OCT. Would you feel that in the future this will replace gonioscopy and disc evaluation, especially in pediatric patients where one machine can give you anterior and posterior segment evaluation?
Yes, I think OCT will be a technology that will come in the future combined in one machine that will allow us to assess both the anterior segment and the posterior segment. It's vital now in pediatric patients because it helps us do tests that we otherwise are not able to do, like gonioscopy and visual field testing. So using the OCT to measure the optic nerve or the macula in pediatric glaucoma or glaucoma suspects can be very useful in managing or detecting their glaucoma. Looking at the anterior segment with infrared light, that is basically OCT, is going to be very useful because it can tell us the true nature of the angle without shining a light in the pupil. The gonioscopy may be replaced in part by OCT in the future, but will not be replaced completely, because even if you have OCT, one cannot detect neovascularization of the angle, one cannot detect the overall structure of the angle, because OCT gives you cross sections and doesn't give you a overall appearance. So in the future, I think those two instruments will be combined in one, but you will still need the traditional techniques of imaging, such as the 78 diopter lens to look at the nerve and the gonioscopy to look at the angle.
When you consider only the posterior segment, do you feel the OCT has an edge over the GDX and HRT?
Yes, the GDX and HRT are based upon pseudo measurements. They are measuring polarization of the nerve fiber layer, or they're measuring a SLO measurement of the HRT, looking at the measurement of the reference plane versus the level of the neuroretinal rim. Whereas the OCT technology gives you the cross-sectional optical measurement of the structure you're looking at. So it is not a pseudo measure, but a real measure. And therefore, it can be used to not only measure just the nerve fiber layer, it can be used to measure nerve fiber layer and ganglion cells. It can also be used to measure the entire retinal thickness, which, if it is reduced, it can clue you in to the fact that the person might be losing ganglion cells and nerve fiber layers, since other layers are not affected in glaucoma.
Dr. Asrani, you worked with various tonometers. What's new on that front?
On the front of tonometers, the eye care tonometer is going to cause a revolution in our field because it is fairly accurate. It is also able to do the measurement without an anesthetic, and it is very patient friendly. We have recently completed a study in which we looked at 130 patients using the eye care tonometer by themselves to measure their own pressure, and we found that they were fairly accurate when compared to the technician measuring the pressure with the eye care tonometer, and as accurate as the Goldman tonometer almost in most cases. So we found that it could be a good tool for using at home by the patient. The difficulty is the cost of the instrument that precludes currently the ability of patients to take that instrument home with them to measure their pressure. But I understand that the company is coming out with a new instrument called iCare One, which is to be an instrument that the patient can buy for themselves, take home, use it, and give it back to you, that can give you data for multiple days as to what the pressures have been over the days, and they can measure it at home. So that's the latest in the self-measurement of pressure. In terms of the dynamic contour tonometry, the microchip of that tonometer tip has now been incorporated into a contact lens that can be used to send measurements via telemetry outside to a telemetry recording device, so we can get measurements at home via that device. The ocular pulse amplitude that is also measured by the DCT or the dynamic contour tonometry has some value in glaucoma diagnosis because it may correlate to the blood supply of the optic nerve. So these are the newer things in tonometry.
So what's your experience with the ORE like? Do you feel that it will really revolutionize the way we look at IOP recording and the IOP measurement as a whole?
The ORA, or the Ocular Response Analyzer, is a instrument that we used it for a little while, but we haven't been using it very frequently in our clinics. And that is because we possibly don't understand the full importance of corneal hysteresis. Yes, corneal hysteresis is important because we measure pressure through the cornea, and the elasticity of the cornea might give us a clue as to the elasticity of the sclera and the lamina cribrosa, which might play a big role in the glaucoma development and management. But until we understand its importance and its role it plays, we don't know what to do with all those numbers and measurements that we get out of the ORA. So currently we are not using it that frequently, but it might play a bigger role in the future.